Hello, I'm Tony DeMaria, the editor of JACC, here with the highlights of the December 11th issue. Heart failure is a common problem in patients with breast cancer who undergo treatment with anthracycline agents. Now, the mechanism of this cardiomyopathy isn't clear, but it's believed to be related to oxygen-free radicals and inflammation. Now, statins can benefit oxygen stress and inflammation. And so an important study in JACC examined whether or not women with breast cancer who are being treated with anthracycline and receiving statins would have a reduced incidence of left ventricular dysfunction and heart failure. And the primary endpoint here was heart failure hospitalization. And they were able to gather the records of approximately 600 patients and follow these patients along. And what they observed was that there was a marked reduction in heart failure hospitalization in breast cancer patients who were receiving anthracyclines and statins than in those patients who were not receiving statins. Now, this is clearly a very important finding. One could argue that it's an association at the moment, and there are mechanisms that could be speculated upon. Nevertheless, these data are retrospective but very encouraging, and we look forward to seeing a prospective trial to determine if in fact statins can dramatically reduce this important complication of anthracycline therapy in breast cancer patients. The risk of discontinuation of dual antiplatelet therapy in patients following PCI continues to be an issue of controversy, but especially in patients who undergo percutaneous intervention in saphenous vein bypass grafts. And to answer that question, a paper in JACC looked at some 600 patients who had received percutaneous intervention in saphenous vein grafts and were placed on clopidogrel and aspirin, dual antiplatelet therapy. And what was observed was, importantly, that in the first 90 days after the discontinuation of clopidogrel, that there was a dramatic increase, about a 25% increase in the number of significant events. And in fact, there were over twice as many events that occurred in the first 90 days, a clustering in these first 90 days, as compared to the subsequent year or two of follow-up after discontinuation of clopidogrel. Now, it occurred that possibly the clopidogrel was discontinued because of bleeding, but this was factored out in this analysis. Another important question was whether the occurrence of events, additional occurrence of events in the first 90 days was related to the duration of clopidogrel therapy, and in fact it was not. There was the same clustering in the first 90 days, whether clopidogrel was given for 6 months or a year or 2 years or more. So very interesting information, something that we need to be aware of in the patients who've undergone PCI for saphenous vein bypass grafts. When the time comes for discontinuation of dual antiplatelet therapy, if it comes, we need to be particularly vigilant in those first 90 days. One of the well-accepted axioms in medicine is that salt reduction is important, particularly in hypertension, and very important in reducing the risk for heart attack and stroke. But the question exists as to whether the benefit of salt reduction is merely related to the reduction of blood pressure or whether there are other mechanisms. And to test this, a group of investigators who are publishing in JACC took a group of hypertensive middle-aged individuals and initially put them on a low sodium diet and then subsequently on a high salt diet and examined the effect of salt upon endothelial function. And what they found was that the low salt diet clearly improved and ameliorated both macrovascular and microvascular endothelial function, looking at brachial artery reactivity according to standard techniques. Now, the mechanism of this seemed to be related to NO, nitric oxide availability, possibly through involvement of nitric oxide synthetase and the ability to reduce oxidative stress. Nevertheless, another reason to have our patients reduce their salt intake, not only for the benefit on blood pressure, but also for the benefit on endothelial function. An interesting question that was examined in this issue was the relationship between atrial fibrillation and ventricular fibrosis. Now, the particular type of ventricular fibrosis was diffuse rather than the so-called replacement fibrosis that's seen post-infarction and is typically identified with late gadolinium enhancement. Here they use T1 imaging to look at a diffuse increase in myocardial fibrous tissue not associated with a destruction of myocytes. And what they found was that, in fact, as compared to controls, there was an increase in fibrosis in patients with atrial fibrillation. And the more advanced degree of atrial fibrillation, that is persistent versus paroxysmal, the greater the amount of fibrosis that was present. Now, whether this fibrosis in the ventricle was the result of the atrial fib or contributed to the atrial fib really was not able to be determined. But I think the message that comes clear is that atrial fibrillation clearly is not a disorder that's limited to the atria, that the ventricles often are abnormal, either in producing the AFib or as a result of the AFib. And in fact, they did have a small group of patients in whom there were not other risk factors for fibrosis other than atrial fibrillation, and nevertheless the fibrosis was present. So a story that may evolve over time, a new descriptor of patients with atrial fibrillation that may have prognostic or even therapeutic significance. So more clinically relevant articles in this December 11th issue of JACC. I hope you look forward to reading them.